on this August evening. We have 3 interesting talks coming up. All the talks are going to be on post-COVID scenario. So as COVID epidemic is advancing, we are now seeing patients who have recovered from COVID coming back with complications. We have 3 eminent speakers who are extremely experienced in this field, handling these cases for the last few months. So first will be Dr. Sekar. I don't think anybody requires any kind of introduction to Dr. Sekar. He's a doyen. He's been a teacher to most of us. And one thing which I want to say about him is even before we started thinking about something, he'll introduce it. So I guess in South India, he must be having the largest number of vascular, especially peripheral vascular complication post-COVID. Over to you, sir. Dr. Sekar, please.
Good evening, and thank you, Dr. Vijayalakshmi, for that introduction. So we are in the middle of this serious pandemic, COVID-19. What started off initially as essentially a respiratory infection causing mortality. As we understand the disease more and more, now we realize it is not a respiratory disease. It's basically a vascular disease. A majority of those varied symptoms of COVID can be explained only when we understand that it's the endothelium which is getting infected, which is getting damaged, and it is getting thrombosed, which is responsible for this myriad of symptoms that we are seeing in COVID-19. And of late, we have been seeing a very, very high incidence of thrombotic events, both venous as well as arterial. And just to give you a brief introduction about what is happening in the international literature, you can see what has been reported as a cumulative vascular event of nearly 31%, out of which nearly 27 involve the veins and 4% involve the arteries. Arteries, we have seen peripheral arteries, myocardial infarction, stroke, mesenteric involvement, cutaneous ischemic lesions developing due to the involvement of small blood vessels in the skin, and COVID-TOS, the digital ischemia, patient presenting with distal ischemia alone. And in children, it has been shown to produce something like a Kawasaki syndrome. And see, as we know that the cause of respiratory failure and VT is basically a coagulation disorder and generalized endothelial dysfunction, and later goes on to develop hypoxemia. And it is said that a gel-like material is released into the lung, so the lung becomes heavy, and that's why even ventilation does not really help in these patients. And pulmonary intravascular coagulation and thromboinflammation, that's another reason why there is a severe hypoxemia. It's not a pulmonary embolism like the classical embolism that we see in a patient with DVT, where you have a large amount of clot in the leg or in the IVC, which embolizes into the main pulmonary artery. This is not that kind of a pulmonary embolism. It is a microvascular thrombosis, inside the thrombosis in the intravascular space in the lung. So that is the reason why ventilation as such is not very helpful, and excellent results have been reported with heparin therapy as well as even thrombolytic therapy has been used to improve the condition. Just a brief word about the kind of hypercoagulable state that we see. We have all the coagulation parameters are completely gone haywire, and so we can recognize with simple tests like with the D-dimer, which goes very high, and also elevated fibrinogen levels, which definitely gives us an idea that the coagulation is at fault, and this patient is likely to develop clottings in different parts of the body. And this has been proved with autopsy findings in the West, where they have shown severe endothelial injury with presence of intracellular virus, which is a very strange thing, which we have not seen it in other virus diseases. We have seen intracellular virus inside the endothelium. So when the endothelium ruptures, there is a raw area that is produced, which undergoes thrombus. So our whole even the treatment strategy has changed once we have realized that things are going to be like this. So instead of giving more and more of antiviral treatment, we have to give treatment towards stabilizing and protecting the endothelium, which will produce better results in these patients. So there is disrupted cell membrane and widespread thrombosis with microangiopathy in multiple vascular beds on postmortem specimen. This can explain thrombotic events even in mild infection as well as in those developing after discharge. This is a very important thing that we have now started seeing more and more patients with very mild symptom. Practically they had fever for a day or something, or even nothing at all, so little malaise, and they develop after a week or 10 days, develop thrombotic events elsewhere. And same way, those who have recovered from a lung infection, gone home, or coming back with thrombotic events in different places. So, who are at risk for thrombosis? Diabetic people, hypertensives, those with coronary artery disease, those who are having active cancer, previous vascular disease or intervention, obesity more than 30. So this is another important thing. We have seen young people who are obese are developing thrombosis without any of the other comorbid conditions. And of course, older age. And we can also add renal failure, because many of the patients on renal failure on dialysis are really prone to develop this COVID disease. And the biochemical marker we have is a very high D dimer and elevated fibrinogen that should alert us that this patient may end up with a thrombotic event. And we have to take appropriate measures. So what are the lessons learned in these things in the treatment of this COVID? In spite of heparin, so initially when it was realized that there is thrombosis, heparin prophylaxis was started. So prophylactic dose is much less than a therapeutic dose. So in spite of what was found was, in spite of heparin prophylaxis, the incidence of PTE continued to be high in these patients. And Middletop reported that about 20% of the COVID-19 patients who had venous thromboembolism, despite routine thromboprophylaxis with a prophylactic dose of low molecular weight heparin. So that is why administration of therapeutic dose of low molecular weight heparin was advised in all hospitalized COVID patients instead of prophylactic dose to reduce this incidence. And it has been shown that it did reduce the incidence of DVT, even though it does not eliminate completely, but it definitely significantly brought down the incidence of thromboembolic events. The other important thing about heparin is clinically used as an anticoagulant. It also has anti-inflammatory properties, including binding of inflammatory cytokines, that is, and inhibition of neutrophil chemotaxis, and protection of endothelial cells, and potential possible antiviral effect. So because of that, heparin has been used extensively. In fact, there are case reports which have mentioned that use of unfractionated heparin in the postoperative period after surgery for these COVID patients has shown less incidence of thrombosis, rethrombosis, as compared to use of low molecular weight heparin. So routinely we have started using unfractionated heparin in the initial 48 hours and then switching on to low molecular weight heparin. So heparin should be started very early in treatment in all these patients. And it has also been reported that high incidence of VT, thromboembolic events, amongst non-ICU and non-critical patients. This is what I've been telling you, that even mild infection patients have come back, have developed or have come back with thromboembolic events. We recently had a young chap who had extensive DVT with involvement of the IVC and the pulmonary embolism, that we had to thrombolize for that. And it is also noticed that arterial thrombosis happens as the first presenting symptom of symptom. That is, patient does not have any respiratory symptom at all. The first symptom is the arterial occlusion. We just recently had a similar patient like that who denied any history of fever or respiratory illness. But the presentation was classical of COVID, the kind of thrombus that we had, and he underwent surgery. And when we did an antibody study in him, the antibodies were very high, indicating that he did have exposure to COVID. In our own experience, we have seen now enough number of cases of deep vein thrombosis, arterial thrombosis as the first symptom, and in patients with very minimal or no systemic symptom at all. And thrombotic complications are more common in women. Women are more protected than men. And the kind of thrombus that we see is whitish and pretty firm, unlike the other normal thrombus that we see. I'll show you a photograph of that. Hence, many times thrombolysis fails, and or we see rethrombosis due to that intimal damage that has been already there. And what we have suggested that instead of thrombolysis in these patients, it's better to do. See, we reserve thrombolysis if the patient cannot withstand surgery, is unfit, has got severe respiratory illness that he may not withstand surgical procedure. Otherwise, we would advise thromboembolectomy in these patients. So what we suggest is doing a thromboembolectomy and using an intraoperative thrombolysis for the distal arterial bed, because here the thrombus is widespread. It's not that there is an embolus sitting in the major artery and the distal arteries are completely normal. So distal arteries also show evidence of microvascular thrombosis, which we cannot remove by open surgery. So there we advise that we do a embolectomy and use intraoperative thrombolysis so that the distal arterial tree can be clear. You see this patient. He came, he was admitted in a COVID hospital with severe infection. He was treated, and towards the end of a week, he developed a pain in the leg. He was discharged. He was put only on aspirin and he was discharged. And then he continued to have pain. He developed an ischemic ulcer and somebody did even an IND in that. Then he came to me. So by which time it was almost a month old. So a month-old thrombus will be stuck, and here is a situation of inflammation where the arteries are also inflamed, the thrombus will be adherent, so it will not work. Anyway, since the patient had lung disease, we went ahead and tried a thrombolysis, but thrombolysis did not dissolve even a centimeter of the thrombus. In fact, what happened was along the catheter of thrombolytic catheter, there was fresh thrombus developing. So we abandoned the thrombolytic procedure. And then we took him, fortunately, he had, you can see here, this is the plantar artery. Fortunately, this plantar artery was patent, so we were able to do a bypass from this point, the tibioperoneal trunk, all the way down to the plantar artery. That's what you're seeing here. This is from the tibioperoneal trunk or the popliteal artery, and then from there to the plantar artery here. So with that, we were able to salvage his leg. He, of course, lost his toes, but at least we were able to save the heel after this. This is another gentleman that I talked to you about. He came from Andhra, actually. He was shifted with acute leg pain and not getting relief. And history-wise, he said he was absolutely all right. He had no fever, no respiratory symptom. Everything was fine till one day he developed severe leg pain. And by the time he came, it was already 5 days old. And you can see here, his CT also showed the lungs were normal. It did not show any evidence of infection. You can see here the thrombus that is there in the common iliac artery. It is also there in the lower aorta. From this, it has embolized into both the popliteal arteries. Both the popliteal arteries are totally occluded and with some reformation in the tibials. So we went ahead. He was otherwise a fit man, so we went ahead and did the thromboembolectomy. So with that, we were able to pull out. So like you see here, this is the thrombus that was there in the common iliac. So you see here it is whitish, and when you feel the consistency is pretty firm. And we have done a biopsy in this. It shows inflammatory cell infiltration also, along with an impacted platelets and other things. See, this is the typical tail clot that is attached to the. This is the typical tail clot. This is, see, when you give a thrombolytic therapy, this tail clot can dissolve, but this one does not dissolve at all. So there is a high incidence of rethrombosis. So you may be forced to use thrombolysis in some of these patients, but you be ready for a failure, and if it happens, then be ready for doing an open surgery in these patients. And so, having learned our lesson in this, now what we are suggesting is this. Many of these patients, even though they apparently got cured, the fever subsided, the lungs are okay, and they are put on vitamins and other things, they also must be put on thromboprophylactic regimen. So we saw the patients who are at high risk, the patients who are diabetic, hypertensive, previous CAD, previous vascular intervention, obesity, older age group, renal failure, active cancer, all these patients must be put on a prophylactic dose of anticoagulation at the time of discharge. So what we prefer is either a low molecular weight heparin, or we can give this newer anticoagulants. It could be a rivaroxaban or it could be a dabigatran. So this should be given for at least 40 to 45 days post discharge. It's very, very important. Same way in even an outpatient setting. In outpatient setting, when the patient is treated as an outpatient because he had very mild disease, did not warrant any admission, even these patients, if they fall into this high risk group, they must be given prophylaxis. Those who don't fall into the high risk group must be given at least aspirin. Nobody should go without either an antiplatelet drug or an anticoagulant. So all patients with COVID positivity must receive either an antiplatelet drug or an anticoagulant depending on the condition. Of course, we need to adjust the dosage according to the liver function, according to the renal function and things like that. But basically, this is the message that everybody should receive some form of antiplatelet drug or anticoagulation to prevent this clotting problem in these patients. Thank you.
Thanks, Dr. Sekar. That was a clear and succinct presentation. So we will take the questions at the end of the session. Now we have Dr. Sridhar coming out with this session now. Dr. Sridhar is the Chief of Critical Care Services. The important thing about Sridhar is his concepts are very clear and keeps it very simple. Whatever he practices is easy for anybody to practice. So over to you, Dr. Sridhar.
Good evening. This is Dr. Sridhar here from Kauvery Hospital, and I'm here to talk about the long-term pulmonary complications of COVID. So the question is, who among those suffering from COVID are much more prone for long-term pulmonary complications? Fortunately, most of them are not. The ones that are prone for long-term complications are those, the small minority of patients who end up needing ICU care, who need ventilator support for a prolonged period of time, and those who are going home on home oxygen or home NIV. These are the group of patients that are most likely to develop long-term complications. Why do we get long-term complications? It could be a combination of various factors. One, the virus itself causes alveolar damage, and this is proven on postmortem findings. It could be the immune response causing alveolar edema, an increased number of lymphocytes in the interstitium causing a fibrotic response, or it could be as a result of the therapies that we institute. The stress injury as a result of positive pressure ventilation can also cause lung damage. The complications that we have seen so far are cough. So we've seen patients coming 3 months down the line after having been discharged, came. Patient is absolutely fine or getting back to where they were, but there's still a nagging, persistent cough. The treatment for cough, we all know that there is no scientific evidence at all that any cough syrup works. If anything works, it is traditional medicine. In this case, it is honey with a bit of warm water and lemon works better than any cough syrup that is available over the counter. The other complications that we see and we are worried about these days are lung fibrosis and bronchiectasis. A little bit more on that later. Pulmonary embolism is quite common in long-term complication of COVID. And this is something that is unique, not that other patients don't get pulmonary embolism, but the frequency of pulmonary embolism is much higher in COVID disease. Superadded bacterial and fungal infections, critical care neuromyopathy and sarcopenia. So this is essentially muscle wasting, as a result of which their respiratory function can get compromised. So although their CT scan is improving, their lung gas section is better, they might be suffering from breathlessness due to extreme neuropathy and muscle weakness, and post-traumatic stress disorder, which is all part of the post-ICU syndrome that people suffer. Once again, this is not unique to COVID. So what is the exactly the lung damage that is happening? The best way to look at this is by looking at the autopsy studies. So two studies I would like to refer to. One in which the average duration of autopsy was 16 days from onset of study, so this is quite early on in the disease. And what we see in this group of patients is diffuse alveolar damage, there is pneumocyte necrosis, congestion, and alveolar edema. None of these findings are unique to COVID pneumonia. Any viral pneumonia would cause this kind of viral ARDS type alveolar damage, and viral particles have actually been seen to be present in the pneumocytes. The second finding that we all know and we are all interested in is the additional presence of intravascular thrombi, especially in small blood vessels. And this, as opposed to alveolar damage, which is characteristically causing ARDS and is not unique, this is a finding that is increasingly seen in people with COVID pneumonia. This endothelial damage causing fibrin thrombi to be deposited. And in this series of post-mortem of about 30 to 40 patients, they found that in small blood vessels less than 1 millimeter diameter, almost 80 to 90% of the cases had evidence of fibrin thrombi. It's quite a huge number. What about when post-mortem findings are done more than a month from the onset of disease? The changes are different. There is evidence of fibroblast proliferation and onset of fibrosis 1 month down the line. And there is micro honeycombing. In other words, the alveolar cells are damaged and replaced by honeycomb-like structures. And these can get bigger, as I'll show during during our discussion of some of the cases that we're going to see. So this is what we see quite common. As you can see, there is the classic ground glass changes, quite extensive, bilateral, subpleural, and a CT scan done a few weeks down the line shows complete resolution of changes. And this is what we see commonly. So this, on the other hand, is a 60-year-old patient who came to us about 2.5 to 3 months back. He was getting increasingly breathless, but there's a delay in the family bringing him to us. So we sent an ambulance out to him as soon as we got the call. And before the patient reached the ER, had a cardiac arrest, was immediately commenced on CPR. As the patient was transferred from the ambulance, resuscitation was continued in the resus bay in ER, and there was return of spontaneous circulation. And once there was return of spontaneous circulation, patient was transferred to the ICU via the CT scanner, and this is what it showed: about 70% lung involvement, bilateral extensive consolidation in the bases, and ground glass shadowing more on the right side and the left side, but extensive changes really. So this is him a month later. We did a tracheostomy, weaned him off from the ventilator for about 3 weeks, and after we weaned him, we decided to get a CT scan of his chest to see what's happening. And then we see the classic changes that were described in the second post-mortem study. 1 month down the line, we can see changes of fibrosis. We can see some of the bronchi are dilated. And we can see this very interesting finding of left hydropneumothorax. So we were scratching our heads, wondering what to do. And as I usually tend to do in these situations, we decided to do nothing because the patient was clinically doing well. This patient also had a CT scan of the head, which showed bilateral stroke. So this patient had a cardiac arrest, had neurological manifestation in the form of a stroke, had extensive lung disease, had every problem of the 3 major organ systems. We managed to decannulate him and we sent him to rehab, and he walked into meet us yesterday. It was very gratifying, really. So we decided to repeat his CT, and this is what we saw. So we can see that most of the lung changes are resolving. The lung looks a lot better, and the hydropneumothorax is almost disappeared. So this patient actually walked in, uh, thanked us, spoke really well, and made us all feel proud of the job we're doing. So this is another patient who was transferred in from a different hospital because of non-improvement. So we did a CT as soon as he came in, and clearly this was the reason why he was not improving. About 3-4 weeks down the line, extensive lung glass shadowing, almost every part of his lung was involved, and also some degree of basal consolidation. So we persevered, we gave him high flow nasal oxygen, and when he tired of breathing, we gave him short bursts of NIV. We were doing everything we can to try and avoid intubation. Now there are two schools of thought. One school of thought saying we should intubate early. The other school of thought saying we should try and delay intubation as much as we can. While there are merits and demerits for both schools of thoughts, in my mind there is no doubt that somebody presenting as late as this, if we try and intubate, definitely the outcomes are going to be worse. So this is him after 1 month stay with us, still extremely oxygen dependent, still needing high flow nasal oxygen, still needing intermittent NIV, and we can see now these changes of fibrosis and bronchiectasis is starting to get more and more established. There was another interest as well. We also found some pneumomediastinum on the CT, and clinically there was some subcutaneous emphysema over his neck, and we felt that if we intubated him, then the chances of pneumothorax and worsening of lung exchange was very high. Fortunately, he carried on with a very high respiratory rate, 45 breaths a minute. He struggled, did not need to intubate. Gradually, he turned the corner. We did not use anything other than the usual steroid 10-day dose that we tend to use. No other medicine was used, and we could gradually get him down to a couple of liters of oxygen, and he spent more and more time with oxygen, and he was discharged home. We're waiting for a repeat visit from him, and once it's done, we'll get a CT and we'll try and share what that shows. So we talked about how the virus attacks the pneumocytes, causes alveolar damage. We talked about how pneumomediastinum can happen. That's a result of alveolar damage. And here there's a cyst as well. Once again, we managed to take care of this patient without having to intubate him. And we do worry that what happens when patients with clear alveolar rupture and cysts and pneumomediastinum, and we ventilate them and use airway pressures. I have no doubt that we'll be blowing up these pneumothoraxes, and at all costs, avoiding intubation in this group of patients, if at all possible, I think personally is a good idea. So this is a patient from a different hospital. Once again, severe ARDS there, was ventilated, treated with a variety of immunosuppressants and antibiotics, and transferred to us because patient was getting breathless. Patient came in ventilator independent but had a fever, and inflammatory markers were high once again, and a CT was done which showed a cavitating pneumonia. I don't know if you can see the cavitating pneumonia actually communicates to a bronchus. So there's no way we could put a drain in, we would just result in a bronchopleural fistula. So we elected to treat him conservatively without putting a drain in with antibiotics. There's also an air fluid level. And this is a clear case of bacterial superinfection causing necrotizing pneumonia. And this patient unfortunately died, had a cardiac arrest from which he could not be revived. So this is another patient who spent a long time with us, needed high flow nasal oxygen, was in the hospital for more than a month, gradually started to get better, and we sent him home on home oxygen. 1 week after going home, developed further breathlessness, and then came back to us. We did a CTPA. There was no worsening of his lung injury. It was similar to what he had before, but he had this new finding of pulmonary embolism. So we started him on rivaroxaban. I mean, any new oral anticoagulant will do. I just chose rivaroxaban, and now it's 3 months down the line. He's back to work. doing his usual activities. It took him almost 4 to 6 weeks to come off the oxygen. He went through periods where he got tachycardic, and but he's gradually improved, and he's back to his routine work. And we are stopping his rivaroxaban because we think this was a provoked P as a result of the inflammation and him being bedbound while being oxygen dependent. And following a 3-month course of rivaroxaban, we are now stopping his anticoagulants. So I shared a few of the interesting cases that we've had. In essence, patients with extensive lung disease requiring ICU, long-term stay in ICU, NIV, invasive ventilation, they're all at risk of long-term damage. So they need to be monitored. The right time to look at them is unclear, but anywhere between 6 to 12 weeks sounds like a reasonable time for you to call them to come back, reevaluate them, look at their functional status, how far they've improved, whether they've been able to come off oxygen, repeat imaging if required, and if there is any new onset breathlessness at this point when you discharge them. We always say there's a new onset breathlessness, do come back. They're all clearly monitoring themselves with portable pulse oximeters, and they're all very good at it. Once again, we say there's a drop in saturation, come back. So any new onset breathlessness, we need to rule out pulmonary embolism, the unexpected worsening of the disease, and complications like lung fibrosis. There's a lot of discussion about what do you do when you know these patients are going to go in for fibrosis. Do you use steroids? Do you use pirfenidone? I clearly concerns about continuing use of steroids in this group of people. Using steroids in hospital in them itself is quite challenging. They have most of them, as you know, have got diabetes. Managing the hyperglycemia that happens is quite challenging. Furthermore, we're worried about secondary bacterial infections, secondary fungal infections. So I personally believe that the disadvantages of long-term steroids in them far outweigh the potential unproven benefits of using steroids. Pirfenidone, once again, I do not use in any of my patients, and there are no studies as of now saying that it has benefit. I do know some of my colleagues do use them, but I would like to see some hard evidence before using any medicines. But it is gratifying to see most of them getting better. All the patients we sent on home oxygen have now weaned off oxygen. Quite a few of them have returned to normal levels of activity, and I think the long-term damages that we see will get better with time, and as we follow them up 6 months down the line, 1 year down the line, I'm sure that their functional status will improve, and I'm quite optimistic that we get them out of the hospital and they will do well. Thank you.
Thanks, Sridhar. So you've answered few questions before even the questions were put in. So after Dr. Sridhar's succulent talk, we are going to have the neurologist. He's going to talk about neurological complications. Dr. Sivaraj, Vishwesh, can you log it down?
No, I'm just connecting now.
So we initially started with vascular complication, thrombosis in the peripheral vessels. Then we ended up talking about damage in the lungs, including vascular damage. Now we're going to talk about neurological manifestation. So Dr. Sivaraj is going to talk about both vascular and non-vascular manifestation, which we see with COVID usually, especially after post-discharge. Are we ready, or shall we take some questions?
Okay. Hello, good evening, everybody. I'm Dr. Sivarajan, Thandeswaran, stroke and neurovascular consultant at Kauvery Hospital. So it's a great opportunity to interact with all our doctors across Chennai and beyond on neurovascular complications in COVID and post-COVID. So we all are in the midst of this nasty pandemic, and yes, quite a lot of us have gone through tough situations, have possibly lost close friends and family, and we are facing a lot of difficulties with the loss of a lot of our patients and so on. But as the pandemic evolves, the knowledge behind COVID is also rapidly evolving, and it's a good opportunity to share what we have read through amongst the big journals, and also a personal experience among treating COVID patients. So, in my first slide, I've got a picture, electron microscope picture of the coronavirus with all the spike proteins with the red arrows showing them. And in the picture B, it just shows the glycoprotein makeup of the spike protein. The composition, the red is the S2, and the green is the RBD, which is the receptor binding domain that sits on the ACE2 receptor on the cells, which through which they gain entry into our cells. Angiotensin converting enzyme is pretty abundant in all our cells seen across our body, including vascular endothelium and neuronal cells, and so on. So as they enter the cells, they replicate very rapidly, and using our own DNA and our own genetic material, and it breaks down our cells. In the process, our body tries to generate immune response, and in a very few unfortunate amongst us, we generate a very robust and deleterious immune response, which starts breaking down our own protective mechanisms. So the viremia can lead to inflammation, which in turn can trigger coagulopathy, and it can also directly attack the endothelial cells, causing vasculitis. And the combination of these can cause thrombosis and thromboembolism. And a subset of them can go on to develop strokes. Some of them may go on to develop large artery thrombus in the aorta, in the iliac vessels or brachial vessels, leading to limb ischemia. We have also seen patients having mesenteric artery thrombus, leading on to bowel ischemia, and so on. So yes, there is a very busy slide. It just shows how the virus can gain entry into our neurovascular unit. So our neurovascular unit is a very tightly guarded cell and organ in our body, and it is protected by the blood-brain barrier, astrocyte epithelium, and also the tight cell lines across the pericytes and also the microglia. So what happens in SARS-CoV-2 is as soon as they enter the enterocytes or the alveolar type 2 cells, they start generating our innate immune mechanisms, and it starts a milieu of interleukins, which in turn trigger increased neutrophil, macrophage, monocyte, and T cell response, and which in turn can stimulate a lot of tumor necrosis factor alpha and macrophage function, and T cell regulatory mechanisms, which lead to hyperinflammation mediated injuries. When they attack the endothelial vessels, it can cause endotheliitis, which in turn can cause diffuse permeability of the cell lines, which again, after the injury to the cell wall, causes coagulation cascade activation and multi-organ dysfunction. In the neurovascular unit, the impaired endothelial autoregulation, the endothelial membranes in our brain cells have a direct link to our adrenal system and also the neurocardiogenic system, which regulates the blood flow, blood pressure, and so on. It causes a disruption of that autoregulatory mechanism, leading to vasospasms inside the brain vessels, and the blood-brain barrier disruption can lead on to increased immune activation with the microglia and metalloproteinases. Hyperperfusion due to vasospasm can also lead on to small ischemic strokes and also large artery strokes. Neuroinflammation is again another area where a lot of post-COVID patients may go on to develop a lot of post-inflammatory conditions like autoimmune inflammatory conditions that we routinely see in routine practice. So, like post herpes simplex virus, we see high incidence of NMD receptor encephalitis. Same way, post-COVID encephalitis is also a big reality. So, broadly speaking, neurological manifestations can be divided into central and peripheral. The central, often majority of the time, it may be simple headache, dizziness, or impaired consciousness or confusion. Often we have come across patients saying they have a little bit of brain fogging, they can't think straight, they have to struggle to recall names and the dates and so on. In a severe scenarios, it may go on to develop encephalopathy or delirium. Seizures is also picked up quite a lot. Syncope and strokes, which I will talk in more detail as we go on. Encephalitis, myelitis, optic neuritis, and again post-infectious autoimmunity is a big area. Again, in milder patients, we may see anosmia, dysgeusia, cranial nerve palsies, facial nerve palsies, ulnar median nerve palsies, foot drop. Guillain-Barré syndrome, we have seen at least 2 patients in the last couple of months. Myasthenic or myositis like muscle injuries also seen in an increase in numbers. So the pathophysiology behind the strokes thought to be due to vasculitis, due to endothelial injury, which in turn triggers hyperimmune situation leading to hypercoagulability and microvascular thrombosis. Cytokine storm is again an independent risk factor for stroke due to its own deleterious effects. The viremia can attack the myocardial cells directly and cause myositis, cardiomyopathy, and arrhythmias, which in turn can lead on to cardioembolic phenomena leading to strokes. Systemic hypoxia on its own can lead on to large territory strokes, encephalopathy, and so on. Fresh DVT is picked up in very big numbers in a lot of studies in France and UK. And in one of the studies, they picked up almost near to 90% of ICU patients were noted to have deep vein thrombosis. And we all know that the incidence of PFOs are pretty high in general population. And in those, we often think of cryptogenic strokes during COVID time, maybe due to paradoxical embolism from the right to left. So we do come across CNS complications even without pulmonary complaints. Right from the beginning, pulmonary complications has been the main focus, but there are patients who come without any lung involvements and with direct CNS involvement. Large artery strokes are often seen post-discharge, and that's also again seen in very young patients in their 40s to 50s. Large artery strokes are not very common in this age, and COVID-19 has got direct mechanisms that leads on to large vessel thrombus formation. And these viral particles can directly infect the brain parenchyma and cause brain encephalitis. And hyperinflammation provoke parainfectious autoimmunity, as we discussed earlier. So how does the virus enter the neural cells? So there is enough literature to show that the previous SARS virus, SARS-CoV-1, has been shown to cause neuroinvasiveness, and the same is being extrapolated to the SARS-CoV-2. And in multiple centers, it has been detected in the CSF in those with encephalitis, and the presence of virus has been confirmed in neural and capillary endothelial cells in the brain of COVID-19 patients on autopsy. The routes of entry may be due through retrograde axonal transport via nasal cavity through the cribriform plate. That's when patients develop anosmia and so on. It can be hematogenous, spread by infecting the blood-brain barrier, endothelial cells, blood CSF barrier, epithelial cells, or using the inflammatory cells as a decoy. They enter the inflammatory cells, and the inflammatory cells enter the blood-brain barrier to protect us, and they can get in and spread into our neural cells. And we do know that ACE2 receptors are abundant in CNS endothelial cells, microglia, and astrocytes. So endothelial, so apart from direct neural entry, endothelial dysfunction and hypercoagulability are the other two common serious mechanisms through which strokes can happen. So endothelial dysfunction is just briefly touch on. ACE2 receptors are expressed in cerebrovascular endothelial cells that regulate the sympathoadrenal system, vascular autoregulation, cerebral blood flow. The virus binding to CNS ACE2 receptors can lead to disruption of its autoregulatory function, leading to blood pressure surges and even vessel wall rupture, which can lead on to subarachnoid hemorrhages, intraventricular hemorrhages when they affect the choroid plexus. We have, as I said, come across quite a lot of large artery strokes, and these patients are often found to have associated poorly controlled diabetes, hypertension, and coronary artery disease. So that's a very key point to note that those who have poorly controlled diabetes, hypertension should take it very seriously and try and control it promptly. With multiple tiny vascular injury, we do see punctating infarcts in multiple vascular territories. There are case reports of press-like phenomenon, so posterior reversible encephalopathy syndrome, where we do see edematous posterior part of our brain, occipital parietal lobes, with white matter changes. There are changes, especially the neurovascular changes, the cranial nerve changes are commonly seen because of our brain's architecture. There's a lot of circulatory changes that happen in the brainstem and basal systems. So it leads on to multiple cranial nerve involvements. So coming to coagulopathy, I'm sure Professor Sekar would be talking in depth with coagulopathy and endothelial injury. I just want to briefly mention D-dimer fibrin FDPs elevated in patients with COVID-19, and the numbers are more higher in more sicker patients, whereas antithrombin and PT activity are comparatively lower compared to healthy adults. So there are quite a lot of reports of transient antiphospholipid antibodies being detected in patients with COVID, especially with positive beta-2 glycoprotein IgA and IgG antibodies, but negative lupus anticoagulants. So they are not routine antiphospholipid patients, but they have a transient antiphospholipid syndrome due to direct COVID-19's effects. Sepsis and subsequent DIC can be a potential reason for COVID-related stroke and thrombosis. Monocyte and endothelial cell activation leading to cytokine release can result in DIC. Free thrombin circulation without full control by natural anticoagulants can both activate platelets and cause fibrinolysis, leading on to significant thromboembolic phenomena. So the direct neural inflammation can lead on to hyperinflammation in the neural cells. And apart from the stroke, routine stroke presentations, we do have patients having slightly out-of-the-box clinical additional scenarios where they appear more delirious, have a lot of psychotic features, and some of them may progress to deep coma, which is not fully explained by ongoing seizure activity like partial status or non-convulsive status or prolonged post-ictal status. And it doesn't also fit in with metabolic abnormalities or medications effects. So there is a ongoing inflammation directly in the neural cells due to COVID, along with the stroke motor sensory effects. And these symptoms are often concurrent with a rapid rise in the CRP, ferritin, and interleukins. So keeping a close watch on them can give us a trend of when the patient is going to get worse and when they would get better. CSF analysis often is normal. Mildly elevated protein level is probably what is mostly seen with very little pleocytosis. That probably is concurrent with the lymphocytopenia that is noticed in most COVID patients, which is caused by lymphocytic apoptosis due to viral replication related hypercytokainemia. So having a negative lymphocyte count in the CSF should not shy away from making a diagnosis of encephalitis. RT-PCR assays from CSF samples have been negative in those patients again, and it's hard to find them in majority of patients. So a negative PCR assay from CSF should not exclude COVID-19 encephalitis. So a proper neurological assessment combined with serological testing plus CSF analysis, including EEG and neuroimaging, will help us in establishing the diagnosis of this type of particular encephalopathy induced by exaggerated innate immune response due to COVID. So I'll go on to discuss few patients. This is a patient detail taken from one of the articles in the web. So it's a 71-year-old SARS-CoV-2 positive female who presents with altered mental status. She had been noticed to have seizures from day one of presentation, along with rising CRP. And as the CRP level started going up, the seizures become more and more resistant to control. So she was noted to have prolonged runs of 2 Hz generalized periodic discharges, and her seizures started to get better as the CRP levels started to trend down again. And the diffusion-weighted imaging MRI showed numerous punctate foci of diffusion restriction with corresponding ADC changes. So this lady went on to improve with anti-epileptic treatment and steroids, and also immunoglobulin therapy. As her immune response started to stabilize, her seizures and neurological function started to get better. So this is an example of acute necrotizing encephalopathy, which is a post-inflammatory phenomenon. On the top column, you could see patient's MRI showing ventral thalamus hyperintensity on the flare images, along with thalamic and caudate hyperinflammatory intensities. On the bottom row, you can see multiple white matter changes consistent with the ADAM. So in this slide, we have a patient who has typical vascular injury in the watershed areas. We do see surprisingly increased number of watershed area infarcts and hemorrhagic transformations into infarcts, and that often tells us that the large arteries are being affected quite often, which causes hemodynamic changes in the watershed areas. In the bottom row, you could see a patient with COVID showing posterior reversible encephalopathy syndrome with predominant white matter involvement and posterior cortical edema. In this, you could see in the bottom row, you could see M1 cutoff on the left side, with also clots sitting in the anterior cerebral arteries, blocking its flow. So this patient has ACA territory infarcts and went on to improve with usual treatment with post-stroke antiplatelets and anticoagulants. So apart from strokes, there are patients who develop necrotizing encephalitis along with strokes. In this, the angiogram on the top right does not show any major vascular occlusion, but the whole of the right MCA territory is severely affected with a lot of edema and ischemia. And the MRI shows a gyral inflammatory pattern with a lot of microbleeds, which is consistent with neuroinflammation. Unfortunately, this lady did not improve, and she died, and her brain biopsy confirmed the presence of SARS-CoV-2 virus in the brain tissue. So we have a lot of patients who come with large artery thrombus. There is a sudden cutoff of basilar flow in this patient's DSA, and which was successfully treated with endovascular technique, and the post-treatment showed a small infarct in cerebellum and brainstem. And in this, in the bottom row, you could see vascular occlusions in the MCA vessels, leading on to bilateral MCA infarcts. I'll show a video, not a video, a picture of a patient who we just treated last week, who presented with acute right-sided weakness. And the CT angio on arrival showed a very large thrombus in the left common carotid artery, which is a very unusual place for a 38-year-old fit and well gentleman. And this gentleman has had mild diabetes, but of late has not been controlling it properly. So he did not have any direct COVID-related complaints. His COVID IgG test is pending, and on the top right you can see the clot's extent in the common carotid, and in the bottom right you can see the clot is occluding almost half of the lumen. So he also had a tight left MCA stenosis, which is again unusual. So he had a carotid stenting with good flow in the left carotid system. We did not touch the left MCA stenosis because it was very long segment stenosis, and we didn't want to cause more damage during the intervention. So the next day, MRI confirmed a left MCA territory infarct. But luckily, he has recovered his aphasia and is slowly starting to stand and take few steps with improving lung function. So I'm hopeful that his right arm function will gradually recover in the next 2 to 3 months' time. So this is again one of our patients in Kauvery who came to us with acute right-sided weakness, and the top left MRI picture shows bilateral cerebral peduncle hyperintensities on the MRI, which is again seen on the top right, and unfortunately the whole of the basilar was invisible on the scan. But the patient presented to us very late, and he is currently ventilated and intubated. And a repeat CT scan showed recanalization, spontaneous recanalization of the basilar artery, and we are hoping that he may slowly recover. So apart from this cerebral peduncle hyperintensities, his pons and medulla are intact. He may end up with a significant quadriparesis, and we are going to probably do a tracheostomy soon and try and get him to neurorehabilitation. So this is a study from the Mount Sinai Hospital in New York, where they had seen a lot of evolving large vessel occlusive strokes in the last 3 weeks of COVID outbreak. And you can see in this graph, on a month-to-month average, they see about 20-odd large vessel strokes, but since the outbreak of COVID-19, the number has almost doubled. So we have been trying to reach out to the public not to avoid routine neurological or any medical complaints for the fear of coronavirus, and promptly seek medical advice. But unfortunately, across the globe, there's a study from Hong Kong which shows that the usual door-to-needle time has dramatically increased post-COVID. So onset to door time and door to needle time has dramatically altered. So a lot of patients are coming to the front door very late, so they miss out on very effective treatments in acute stroke, which are IV thrombolysis and endovascular thrombectomies, and go on to become severely disabled and even lose their lives, which could have been easily prevented if they had come quite promptly. So this is a very good information from the Global Stroke Registry, from especially relating to COVID patients. So on the top bar of the ordinal scale, you can see the black bars are those who have died on a routine non-pandemic time frame due to stroke, which has increased almost threefold during the COVID-19 pandemic period. And you can see in the blue bars the number of patients who present with medium to large artery, large strokes, which is in line with the NHS score, is proportionately higher. So how do we manage strokes in COVID patients? So this is a very complex slide which shows the multiple pathways through which coagulation, fibrinolysis, and inflammatory complementary mechanisms can act. So do we think that simple anticoagulation, low molecular weight heparin, or oral anticoagulation would be enough? So I think we should be blocking at multiple clotting points, coagulation points, to achieve a successful end. And there are a lot of studies that are ongoing, and this is a algorithm from the International Society of Thrombosis and Hemostasis, which kind of tells what to do in this scenario with coagulopathy. So it clearly helps us to know if the DML level is raised or not markedly raised, and go through the flow chart and see how we can treat patients. So the general consensus is that we should start prophylactic dose low molecular weight heparin, and the dose doesn't have to be always a low molecular prophylactic dose. It has to be increased in those with a very high D dimer and those who have a low platelet count, especially if they're non-bleeding. And we should try to keep the platelet count above 25 with platelet transfusion if necessary, and sometimes treat simultaneously with low molecular weight heparin and antiplatelets, or antiplatelets plus oral newer anticoagulants. So monitoring of PT, APTT, D-dimer, platelets, fibrinogen, CRP, and ferritin can help us to pick out patients who are at risk of getting thromboembolic complications, and also in the long-term monitoring post-COVID and initiating treatments. It is advisable to start prophylactic anticoagulation with low molecular heparin in all patients with COVID-19. And the dose has to be higher in those with high D-dimer or in those who have confirmed thromboembolism. So we should be watchful for paradoxical embolism. Elderly and anyone with usual vascular risk factor has to be screened meticulously, because they are the ones who are more prone for coagulopathy. And what is the duration of the oral anticoagulation post-COVID is still unknown, but in our center we treat with oral anticoagulation for at least a month with aspirin. Anti-inflammatory therapies can reduce the inflammatory process and reduce the coagulopathic burden. Remdesivir antiviral therapy is known to reduce the hospital stay of patients, so anyone with thromboembolic phenomenon should be offered antiviral therapy. Thrombolytic therapy is routinely done in those patients with confirmed thromboembolism, and there are studies which have gone to recommend that even those with ARDS are being trialed with thrombolysis, because we all know in those with ARDS there are multiple microthrombi in the lung, and they are hoping to see better results in those patients. Endovascular therapy is a lifesaver in many situations and should be promptly offered. So yes, in this COVID pandemic, we have encountered a lot of stroke patients, especially large artery stroke patients in a younger age group. And in the post-COVID scenario, we are hoping to see quite a lot of patients with cranial nerve palsies, like facial nerve palsy, Bell's palsy. I have seen a lot of Bell's palsy the last 6 months than in my entire career. And we probably would end up seeing a lot of patients with seizures, headaches, and other complications due to vasculopathies. So let us all be informed and help all our patients in this very difficult times. Thank you.
Thanks, Dr. Sivarajan. That was a good session. So now we are going coming to the most interesting part of the session, the question and answer session. I guess it's going to be randomly shooting questions, but let me ask the first question. So there is so much of usage of steroids So there are a couple of questions on steroids too. So what we understand is steroids seems to be used for everything and anything. So let me get the panelist opinion on steroids before we go into the question and answer session in detail. First, Dr. Sekar, what is your opinion on steroids? There is a one question from Dr. Vidya who's asked whether steroids can decrease a thrombotic complication. I am adding another question. Do you think the increase in thrombotic complications is it any way related to the indiscriminate steroid use? Or do they have any correlation? What is your opinion?
No, I don't think steroid as such not inducing thrombosis in these patients. I don't agree with that. In fact, we are using steroids in some of these inflammatory vascular diseases, where by using steroids, we are able to prevent thrombosis. So I don't think that statement is right. But I agree with you that indiscriminate use of steroids, high doses of steroid especially, can precipitate thrombosis and also can make the secondary infection and other complications that are happening in the lung. So judicious use of steroid is certainly indicated in these patients. And I don't think they play a part in producing thrombosis.
So in other words, they may also not be, they may also not play a part in kind of avoiding thrombus too.
Yeah.
Sridhar, what about you? Steroids something which we use in Kauvery only for patients who are hypoxic. But what I get to understand, anybody with some pneumonia or anybody who's positive gets steroid given. So what is your view on that?
I think the evidence is quite clear on that. Steroids is beneficial only in people requiring oxygen or on ventilator. If we give it to people who are not requiring oxygen, then the mortality among that group of people is worse. A lot of people die from secondary bacterial infections. The last thing we want to do is give them drugs which are not beneficial for them. Plus, quite a significant proportion of people are diabetic, makes the sugar management also difficult. It is also important to remember that even in people whom steroids is shown to benefit, the number needed to treat is 20. In other words, we need to treat 20 people with steroids for one additional patient to benefit. So use steroids carefully, use it only in the appropriate group of people, i.e. those requiring oxygen or on ventilator.
The next question I'm asking, we have Dr. Sridhar, a diabetologist. Barney, what do you face when steroids are used as what? What about diabetes and steroids? To be seeing patients with insulin infusion everywhere. So what is your plan about that? Dr. Sridhar, please. Please unmute yourself.
Okay. Thank you, Dr. Vijay. Actually, so I just want to add my views about steroid use and new onset diabetes. So we started in my career. I'm just seeing a number of patients of new onset diabetes during these days. Because after steroids, we started seeing more number of patients. They may be impending diabetes also. After started steroids, the sugar level got very much high, and most of the patients are in infusions. So one thing is actually those patients on controlled sugar level, and then they can just see getting recovery very easily also. That is also post recovery is also very much seen in those patients. And I also often seen that patients coming with COVID, they are impending diabetes also. They have a high HbA1c level of 11, 12, 13, those kind of patients are anything. So impending diabetes also one risk factor for COVID, I think. So people should be screened. That is in our Kauvery. Actually, what we are started doing is all patients coming to the ER itself, we are just doing a random sugar, and HbA1c also is part of our package. So we are just started doing this.
Thank you, Dr. Bharat. Dr. Sivarajan, do you think there is any correlation with steroids and stroke?
I don't think so. Most of the patients who come across have quite typical vascular risk factors. Even though they are young, majority of them with the large artery strokes is high. Those who have sort of risk factors, risk factors are very rare. I've not come across steroid-induced phenomenon, and in peripheral neurovascular neurological problems like GBS, or even with post-COVID neuroinflammatory disorders, steroids help. the case away, like high dose IV methylprednisolone for 5 days. Those who have encephalitis, and we have also gone to treat them with IV immunoglobulins and rituximab. So I think blocking their doing a very strong immunomodulation in those patients, either thromboembolic neurovascular or inflammatory neurovascular, has not shown to cause major adverse effects.
So to sum up, steroid, but again, if we use it irrationally, we'll land up in problems. Optimal usage of steroids in patients who are hypoxic, who require accessory oxygen, who are on ventilator for a brief period of time is probably beneficial. Prolonged usage of high doses may cause more harm than benefit. So next, go to the next question. Anybody has any more questions on steroids, please put it across, answer that. So next question to Dr. Sekar. This is from Dr. Kedarnath. He wants to know, is urokinase, orokinase tablet used as a preventive medicine?
No, the oral kinase therapies are not effective at all. If at all you have to use a systemic lysis. So here, in arterial blocks, we always use intra-arterial. We don't even use systemic because it gets diluted and it does not reach the clot in the correct concentration. So it doesn't work well. So if at all you have to use lytic therapy, you have to do an intra-arterial puncture and give catheter-directed lytic therapy.
Thanks, Dr. Sekar. I'm adding a question.
I want to ask a question on thrombolysis to Sridhar. Have you tried thrombolysis for pulmonary problems? In those patients who don't seem to be recovering or rapidly going down, where you're suspecting, in spite of ventilation, you're not able to maintain oxygenation. Have you tried thrombolysis?
We have. Sridhar, was that patient in ICU or in the ward? We have had 2 patients thrombolized.
On the ward.
So one was a 78 or 80-year-old lady with a pulmonary thrombus. Another was a relatively young man. Both were thrombolized and follow-up echo. There is quite a bit of, there's not much of a problem. I guess one is probably 1.5 months old, another patient around a month back. Both of them are doing well.
I am not talking of the classical pulmonary embolism which Sridhar showed, the one that is there in the main pulmonary artery and things like that, where the pulmonary trunk is free, where you are suspecting is the small vessel microvascular thrombosis. Have you tried using?
Sir, you got my question. That was supposed to be my question. Sridhar, can you ask me? Because now there is a lot of talk about this thrombolysis among the ID field. Everybody is talking about thrombolysing critical care patients. So what is your view on that?
No, I think I'll be very cautious in doing that. If the vessel is not major trunk, if it's subsegmental, I would be happier using treatment dose, low molecular weight heparin, or even IV unfractionated heparin. I'd be very cautious using thrombolytic drugs in this context.
Okay, so there are a couple of questions.
Because we are getting some reports in the literature where they have tried systemic thrombolysis to show that they have improved oxygenation after using thrombolysis.
Now, going on with the steroid, Dr. Raja wants to know any case reported regarding early steroid usage and increased mortality. I would recommend recovery trial. In the recovery trial, they had 4 cohorts. There was one cohort where we gave steroids to people without oxygen. In fact, the mortality on the dexamethasone group was much higher than the usual group. In all the other 3 groups, patient on oxygen, those who required ventilatory care, those who required non-invasive ventilation, mortality was less. There were few other trials and one major meta-analysis, which were all in patients who had severe COVID pneumonia. So as of now, there is possibility, a chance of more damage by using steroids on patients who don't require oxygen. Do you want to add anything, Dr. Sridhar?
No.
Next, Dr. Ravindra wants to know which steroid and dose of steroid used and duration used. Sridhar, would you take this question?
Yeah, so the recovery trial recommends dexamethasone 6 milligram. 7 to 10 days is the usual course. If the patients are getting better, then I like to cut the course down to 7 days. Whereas if they are still hypoxic and needing support, then I complete the full course of 10 days.
So there's one more question probably to you. There's any new drug secondary to the new bradykinin theory? Preferred bronchodilator for asthma, COVID. Somehow our pulmonologist is not here. Sridhar, I guess you could take the question.
No.
Drug secondary to bradykinin theory and preferred bronchodilator for asthmatic post-COVID.
Okay, so no, there are no new drugs I would use, even if there's to counteract this bradykinin hypothesis. As far as asthma is concerned, we use the same standard management: salbutamol as a first line and ipratropium as an add-on, in addition to steroids.
There's one more question on echo post-COVID recovery period. So, who requires echo after recovery? Sridhar?
The ones that I have seen echo being very useful are on the acutely unwell patients. RV dysfunction is quite common in this group of patients. And the reason RV dysfunction happens is, one, because of the pulmonary embolism problem that we were discussing. And, Dr. Sekar also raised this question. It is extensively present. It's there in the subsegmental thing, would you thrombolize? That could be another reason. The second reason we see RV enlargement is because of hypoxemia causing pulmonary hypertension due to pulmonary vasoconstriction. Sometimes we get RV hypertrophy and RV strain purely as a result of the ventilation we're using. Using echo is also useful in these patients who become hypotensive to see whether there's myocardial depression or whether there is sepsis. In the long term, once they're discharged and if there's no concerns about the heart or RV strain, I don't see a need to do an echo later on.
Basically, when patients come for follow-up, we evaluate for possible cardiac risk factors because quite a proportion of our patients getting admitted in the hospitals are diabetics. Quite a few of them have cardiac risk factors. During cardiac evaluation, some of them get an echo done. We don't do it as a routine. It is done as a basis of the risk factor evaluation. So, next question is, another question is anticoagulation for pregnant COVID women. Professor Sekar.
Yeah, there is no contraindication to giving heparin in pregnant women. We can't give oral anticoagulants. We can't give any of the newer anticoagulants. We can only give heparin. Either it can be an unfractionated heparin or the low molecular weight heparin.
And how long do you recommend it?
See,
and you recommend pregnant women?
No, that is, if the patient, we are not going to give to all the pregnant women unless there is a risk of thrombus in them or there is an evidence of thrombus, then they will have to be taken till delivery. If there is no thrombus in them, during this period, like we are saying that around 1 month or 40 days post-COVID, that's the time we have seen them developing thrombus. So we will cover them only for that short period, not entire pregnancy.
So there is one more question on thromboembolism. Is there any need for anticoagulation in all COVID positive patients, both symptomatic and asymptomatic? Any age limit, or is it only based on comorbidities and presentation?
See, this is a $1 million question actually. We are not able to decide who is going to develop thrombus or who is not going to develop thrombus. The D-dimer, a high D-dimer is helpful, no doubt. But a low D-dimer does not rule out developing a thrombus at a later date. That's the problem. So we don't advise an anticoagulation just because the D-dimer is low and the patient comes back later with thrombotic event. So what we are saying is, forget about these markers. All the patients that we have seen have all fallen into this high-risk group. That is diabetes, hypertension, coronary disease, previous vascular disease or intervention, active cancer, renal failure. These are the patients who must receive some form of thromboprophylaxis. And if the patient does not fit into this, he is otherwise having only a COVID positivity, at least give them aspirin.
So what we do is, anybody who's about 5 obese with mild infection, we give them aspirin. Anybody who's admitted requiring moderate to severe disease, we use aspirin and anticoagulation at least for 45 days. Those who have multiple risk factors, it is taken up to 3 months. So adding on to another question, the same thing, any relapses of thrombosis after recovery? Dr. Sachinanandam has asked this question. Relapses of thrombosis after recovery.
What thrombosis?
Any kind of vascular thrombosis, has any of them relapsed after recovery?
Oh, relapse. Yeah, this that is if the patient has had a thrombus earlier and coming back later. So if the patient develops a thrombus in the early period, we always anticoagulate them. As long as they are on full anticoagulation, they are not going to develop another thrombus. What do you mean by relapse of thrombosis? He has to clarify the question.
I guess he's asking about anybody after stopping the anticoagulants, have they come back with thrombus? For example, we quit for 6 weeks. Has anybody come with a thrombotic complication after 2 months or 3 months?
No, we have not crossed that stage. No, we are still in the middle of the pandemic. See, we have realized that the thrombosis is happening since about a month and a half or 2 months. So we are in that stage. We will know the answer only next month, maybe. So as right now, if they have a thrombotic event, the anticoagulation is continued for 3 to 6 months. If they have, prophylaxis only is stopped after 40 days. If they have a thrombotic event, the anticoagulation is continued for 3 to 6 months, depending on the severity of the thrombus.
So there are a lot of questions on steroid. Before that, we'll take one question on cardiovascular syndrome, the cerebrovascular. How common only CVA without respiratory involvement? Dr. Sivarajan.
So the incidence of strokes within with COVID-19 patients is about 2%. It's not extremely high, but that is on top of our usual stroke incidence. So amongst those, half of them are those who are very young with large artery thrombus. So it is not a very big number, but on top of the usual incidence, it's a decent sort of number of patients who would go on to develop strokes.
I think they are asking for mild or non-asymptomatic patient developing stroke as the first symptom.
So the two patients like symptoms weeks large artery stroke. And the current gentleman who basilar artery in mild disease. So there are patients who have had mild disease and go on to develop, but looking through the literature, it's a big mix. There are a lot of patients who are very sick and then went on to develop multiple strokes. Those patients develop tiny punctate infarcts. Those who are very sick, needing prolonged ventilation with concurrent DIC and so on, had microbleeds and small infarcts. Those who went home, presumably very well, came back with acute large artery stroke. So probably there is a big divide. Those who are very sick may go on to have multiple infarcts. Those who are reasonably well may have a slightly higher risk of having large artery strokes. But who are those patients and how do we pick them up? It's still a mystery.
See, I can add on to this. See, we are seeing in peripheral arterial and venous, there are enough number of patients developing thrombosis with absolutely minor symptoms or even no symptoms. I can give you an example of one patient. This girl has had a postpartum DVT in 2012 and I have treated her. Her relative, I think her father or father-in-law, developed COVID. So she got panicky, she got herself tested, the COVID was negative. And promptly 10 days later, she comes to me with a recurrence of DVT in the same leg. She had absolutely no fever, no pulmonary symptom. Her CT was normal. We repeated her COVID. COVID was also normal, but she had a DVT. So it's very difficult to explain why she should develop. You have to put 2 and 2 together and think that the COVID had some role to play in developing DVT in this patient.
So what about antibodies? So is it positive for her?
We have not done that because cost is a factor. But we have seen patients developing fever and leg pain simultaneously. The same day, patient developed fever and leg pain, and patient has been admitted to our hospital itself. We have had patients like that.
So there was one more question to Dr. Sekar. Pediatric anticoagulation.
Say that again?
Pediatric anticoagulation for pediatric patients from Dr. Vijay Kumar.
Yeah. See, pediatric patients, we are not sure of these newer anticoagulations, but we are quite confident of giving our old the vitamin K analog. So we can give acetylene and warfarin depending on the body weight, and we can give the anticoagulation. There's no problem at all. There's nothing special in them.
So are they also more predisposed to thrombotic events?
Yes, we have seen that all these small little lesions in the skin lesions mostly. And then, of course, that Kawasaki disease is a late manifestation. So you have to keep a watch on them to, regarding the coronary arteries and things like that. But generally, the incidence is much less in the children, just like it is much less in women.
Next question to Dr. Sridhar. How many patients had recovered from invasive ventilation in Kauvery Hospital? Did you keep a tab?
No, I don't, but I don't keep a tab. Off the top of my head, I can think of about 7 or 8 patients. I can't remember the exact ratio. But different hospitals follow different policies. Some hospitals are keen for early intubation, some hospitals are keen for late intubation. We try and avoid intubation as much as possible because of the lung problems, adding on to long-term lung damage by ventilator-induced stress, the risk of pneumothorax and all. So clearly, if you are intubating early, you will intubate a lot of people who don't need intubation, and your success rates will be high. Whereas if you're intubating late, you're intubating only the really sick ones, and the number of people who survive will be less. I would say that our success rate is, our survival rate of the ventilator is definitely less than 50%, probably closer to 40%.
So next we'll go for a question to Dr. Sivarajan. Dr. Meenakshi wants to know, majority of our patients are becoming afebrile in 4 days. Is there any marker to predict who will land up with neurological complications? Like either D-dimer, ferritin, CRP cutoff in your experience?
So with the literature, those who go on to develop thromboembolic phenomenon have a slightly higher numbers of D-dimer, interleukin, and the CRP levels. And the levels also fall as they start to get better. So maybe at the time of discharge, or maybe at the time of the convalescence, they can be offered to do these tests and see. But again, as Professor Sekar said, often D-dimer may not be correlating well with the coagulation sort of abnormality. So it is something better than nothing. So you could, so for example, if you have an extremely high D-dimer, extremely high CRP, you could be even more careful in anticipating risk of thromboembolism.
We don't find great correlation between inflammatory markers and deterioration. We find people who have very high inflammatory markers going home quite comfortably, not even needing oxygen. Even on the day they're going home, the inflammatory markers are quite raised. And on the other hand, we find people who are going on ECMO having near normal inflammatory markers. The inflammatory markers are guide, more important is the clinical status of it.
So inflammatory markers, we don't follow patients routinely with inflammatory markers. There doesn't seem to be a direct correlation in our country at least. Next, there's a lot of questions on steroids and stuff. We'll take one more question. Dr. Vidya wants to know how often we should do CT in asymptomatic normal positive patients. Sridhar, that's interesting. CT in asymptomatic normal positive.
Never.
Yes. So if the patient is asymptomatic, if it's especially a young individual, no CT. Let's say an old individual, the patient says asymptomatic, looks dull, weak, looks uncomfortable, comes to OPD on day 5 or 6, not sure what is happening to him. Maybe the person is not identifying hypoxia and temperature. Those kind of patient, when you find a little bit of hypoxia by investigation or a low fever spike, CT is mandatory. But if they're completely asymptomatic, there is no role for CT screening. Going along with that, is there a role for steroids in 10 to 20% lung involvement without hypoxia?
Once again, the extent of lung involvement on CT scan does not correlate with hypoxia. We have people with 80% lung involvement who are not hypoxic. We have people with 30 to 40% lung involvement who are hypoxic. The criteria for onset of steroids is quite clear. It's not percentage of lung involvement, it's the effect of lung hypoxia. So CT scores are not important enough for starting steroids. Hypoxia is.
Adding on to that, your body is trying to control. In the steroid, what does steroids do? It suppresses immunity. And we've all learned in our school and till now that anybody immunosuppressed can develop bad disease. So why should we suppress the immunity when the body is taking control? Once it crosses the control phase, patient becomes hypoxic, suppressing the immunity may help. Early steroid very likely should be experimental. Now, another question on steroid. Can steroid be used beyond 10 days in patients requiring HFNO? By Dr. Radha.
Can steroids be used?
More than 10 days in patients on HFNO.
No, I think the study is quite clear. 10 days is the maximum. More than 10 days, the immunosuppression is not going to achieve anything. So definitely, after 10 days, if there's no benefit, we would be crossing the steroid. And I'll be honest with you, I know there's a lot of questions on steroids, but a lot of people who come from other hospitals or treated in the peripheries and coming back sick, we find on steroids inappropriately at an early stage of the disease, and also sometimes start on antibiotics once again early and inappropriately. Once you're using up all these drugs, then these patients tend to do worse.
Adding on to immunosuppression, Dr. Geetanjali wants to know the role of tocilizumab in COVID. What's the dose? How many days? Sridhar, tocilizumab, our favorite topic.
Once again, we have, at least I have used tocilizumab once under severe pressure and request from relatives who believed at that point it worked. At that point, there was evidence to favor it or not to favor it. So we gave it, and I don't know whether the patient benefited or not. But ever since Roche, the manufacturers have themselves released studies saying tocilizumab does not offer benefit. Now, when the manufacturer of the drug is saying there is no benefit in using it, I would be very concerned about using it. We're also using steroid, on top of it using other immunosuppressant, and then we find an increase we're surprised when we find an increase in the number of superadded bacterial infections. So short answer is, at present, given the evidence and Roche's recommendation, there is no role for tocilizumab.
So we don't use tocilizumab in Kauvery. Next, Dr. Ansari wants to know what is the significance of elevated CRP even after 2 to 3 weeks in asymptomatic post-COVID. Sridhar, you want to take the question?
Yeah, once again, CRP is a biochemical marker. As I said, have gone on the days people have gone ECMO, they've had normal CRP. In the ECMO, you know how severe the disease is. On the other hand, we have discharged people with CRP of 100 because they look quite well and there's nothing else to worry about. I wouldn't worry about the CRP being raised 2 weeks down the line if the patient is doing well, not having hypoxemia, subjectively well, and is able to do all their day-to-day activities. Then I would just see it as a number and ignore it.
Dr. Ansari, also remember CRP has a half-life of around 36 hours. So if you're worried about one value, please don't think about it. So if somebody has some other symptoms with slightly elevated CRP, look for other causes. So in COVID, CRP does not persist high for a long period of time. Persisting for a few weeks after recovery is expected and doesn't do any harm to the patient. Next, oral anticoagulants again. At the time of discharge, which oral anticoagulant is preferred and what dose? Dr. Sekar.
See, the patient requiring an oral anticoagulation as prophylaxis, there are a lot of choices for us. See, regarding that vitamin K analog, which is the standard azithromycin and warfarin, the problem is control. So you'll have to do an INR. So patient has to come to the hospital to do an INR. So what has been advised is you avoid that patient coming out and coming to a hospital or a collection center. You avoid that and use the newer anticoagulant, which is ideal thing that we can use is a rivaroxaban or a dabigatran. Or the other choice is use low molecular weight heparin if they can take in shots every day. So this is how, that is a philosophy. So if you're going to give, let us say a rivaroxaban as a prophylaxis, so you can give 10 milligram of Xarelto once a day, or if you're going to give dabigatran, for prophylaxis, it's a 75 milligram BD is the prophylactic dose. So you'll have to keep a watch on the renal function and the liver function, making sure that you don't end up having extra bleeding in these patients.
Sridhar, which mode of ventilation you prefer? When will you start HFNO?
High flow nasal oxygen. So the choice of the way we escalate is first we use normal nasal cannula. We can use anywhere between 4 to 6 liters. If despite using normal nasal cannula, the patient's saturation is less than 90, and despite proning and they're becoming hypoxic, then we step up to Venturi masks, which you can use 28%, 40%, 60%. So once on 60% oxygen, despite being on 60% oxygen, once again the patient's saturation stubbornly remains below 90, then we would go up to high flow nasal oxygen. The threshold for intubation varies from hospital to hospital. Our threshold is very high. The patient has to be really sick to be put on the ventilator, as discussed before. So if they have refractory hypoxemia to 100% oxygen, if the patient is encephalopathic and is unable to lie prone or cooperate with the treatments that we are expecting the patient to do, or the patient is showing signs of fatigue, tachypnea, persistent tachypnea, use of axillary muscle respiration, or the carbon dioxide is going up, then clearly the patient is going to fatigue and not going to be carrying on for much longer. Then we put the patient on the ventilator. It doesn't matter which mode you use. The key principle is this: the tidal volume should never be more than 450 ml in any of our patients. Anything more than that adds to lung trauma. We know that the alveolus are damaged. You expand the alveolus more, it causes alveolar stress, increase the chance of pneumothorax. Likewise, the peak airway pressures, it doesn't matter which mode you use. I don't care whichever ones your nurses are familiar with is more important. A lot of people talk about fancy modes. The more important thing is we are going to adjust the ventilator mode for about 5 minutes, 10 minutes, and then walk away. And your nurse is going to take care of the patient for the remaining 23 hours. Then it's important that you use a mode that they are comfortable with and ensure and enforce that the airway pressures do not go more than 30 centimeters of water. I think these are the key points. What mode you use is entirely up to you. The carbon dioxide rises a bit, I don't care. I mean, nobody cares. Carbon dioxide can even double. We don't want to increase the stress of ventilation in these people. So low tidal volume and keeping the pressures less than 30 centimeters, the plateau pressures, I think are the key rather than the mode of ventilation.
Thanks, Dr. Sridhar. Welcome, Dr. Anantharaman, our cardiologist. What is the role of prophylactic aspirin in high-risk group? Dr. Anantharaman, please. I guess he's lost. So aspirin we give to anybody with high risk, like anybody who's obese, anybody with any cardiovascular risk factors, hypertension, diabetics. We give at least for 6 weeks. Sometimes it goes to 3 months when the risk is extremely high. After discharge, they're also having a cardiac evaluation done. If the risk factors are more, or they're offered a cardiac evaluation. Dr. Anantharaman is in view. Sir, can you go ahead? The role of aspirin in high-risk group among post-COVID patients.
No, as you said, aspirin is specifically only for patients who already have cardiac history or other issues. Otherwise, during this COVID episodes, we are giving aspirin, especially if we are not giving low molecular weight heparin. But continuing that long term for this COVID patient is not essential, apart from during the hospital stay, unless they have other cardiac issues.
Thank you. Dr. Bharanidharan, there's something about prophylactic antibiotics. What is your view on prophylactic antibiotics for COVID patients? Dr. Bharani?
Okay. So for diabetes, uncontrolled diabetes, definitely prophylactic antibiotics is necessary because people coming with a high HbA1c, so the COVID, actually they are recovering, but they are more prone to get secondary bacterial infections. So that point of time, definitely antibiotics is must for those patients I prefer. So when they are symptomatically better, they are getting discharged, they need antibiotic.
Generally, once it's Once it's proved as COVID, we don't give antibiotics. In fact, we don't even use azithromycin anyway. Only when there is a doubtful of secondary infection, we use antibiotics. The question was about prophylactic antibiotics. We generally don't use prophylactic antibiotics
We
much.
don't have generally use prophylactic. Yes, we don't generally use prophylactic antibiotics. But when they get a secondary bacterial chances, then definitely they need an antibiotic. That is the thing. Especially in the case of diabetic uncontrolled, they are more prone to get a secondary bacterial. At that point of time, we need an antibiotic for those patients.
Thank you, Barney. Next is Dr. Ravindra Bhatt wants to know asthmatics on steroid inhalers. How does it change the course of COVID? Does it favor or worsen COVID? Sridhar, you want to take the question?
I don't think it alters the course one way or the other. The inhaled dose of corticosteroid is not going to be high. It is all limited to mucosal absorption and the point of action. So it is not nowhere going to be equal to the high doses we give systemically IV. And I don't think asthmatics are at a greater risk of lung problems due to COVID than the general population is, unless they have immunosuppressed or they are on high dose steroids for want of better asthmatic control.
There's one question from Dr. Bhairava. Came across a patient today who was COVID positive and treated with Fabiflu for 14 days in July end. After 1.5 months, he's asymptomatic, but CT lesions look like COVID and RT-PCR is positive. Should I treat with antivirals or just give symptomatic treatment? Well, sir, CT takes a longer time to recover and doesn't mean the patient has a pneumonia which is active. RT-PCR does not figure out the difference between a live and a dead organism. So the organism could be dead and it could just be picked up in RT-PCR, may not having the dividing virus. So this could just be a sequelae of the inflammation of the past infection. So in other words, you start treating, don't repeat RT-PCR again and again. Majority of them are non-infective after 14 days. After 3 weeks, they are non-infective. So you need not repeat the COVID RT-PCR. Repeating CT is only to see whether they are recovering, and repeating CT maybe after 1 and 3 months. So routine repeating CT may not be necessary. You don't need to treat this patient. Next is one often case. How about reinfection? Reinfection cases reported. Sridhar, you want to take the question?
So we are starting to see a case of reinfection. I think it's very difficult to know without very good genetic testing whether this is just a continued viral shedding. The reports that come from abroad, they're very clear. The initial viral strain was different from the second virus strain that they grew. So that is clearly a case of second infection. But RT-PCR is nothing but, it's a polymerase chain reaction. We take the viral RNA and just multiply it many times. So even if the virus is dead, the RNA is there and it gets multiplied, and this viral shedding can go on for some time. I think it's very important to distinguish ongoing viral shedding from reinfection.
There are 2 reported cases in literature where they have a kind of documented reinfection. So as of now, we don't know whether it's widespread. Probably it is not widespread. Probably you have immunity after 3 months. But please remember, even when we don't know about it, wear your mask. After some time, we might find reinfection pretty common. Please wear your mask. And that brings us to the end of the session. Thank you. It's been a wonderful time. Yes, sir.
One last question, because it's getting very popular now. What is the role of lung transplant?
Sir.
Sridhar, will you take that question?
I'll take the question, but I won't take any patient who needs lung transplant. Is that okay?
If we have a choice.
To my knowledge, one case has been done in the United States. So for lung transplant. So that's why so much is being written now about lung transplant, including this, our SPB. Suddenly somebody said he's going for a lung transplant.
Yeah. Lung transplant is very tricky. It has been done. I think I've read about a case of a young girl in UK getting a lung transplant and then doing well. I've not followed the case still. But I think lung transplant would be like very remote, very long. It's a very long shot. Plus, it is a very, very scarce resource. To get suitable lungs for lung transplant is going to be rare. And I think we should utilize those things for patients who have the best chance of that are IE young patients.
That brings us to another question. What about ECMO survival? Do we have any data from India on ECMO survival?
I have come across 3 patients that have gone ECMO. All 3 have died, including one at our center. The overall India data, I'm not aware, but I can find out. So the 3 patients that have gone ECMO have all died.
So that brings us to the end of the session. Thanks a lot for this good session. Any further question, please ping on us. We'll answer back. We'll mail you back. Thank you.
Thank you.
Thank you.
Well done, Vijayalakshmi.
Thank you, sir.